Today's lecture is on altered cast procedure. For the tooth-supported RPD, the forces are directed through the rest and transmitted to the abutments. The edentulous ridge does not contribute to the support of the RPD in any way. So as a rule, a single impression that captures the teeth and the soft tissues in their anatomic form is sufficient for the Kennedy Class 3 and 4, both tooth-supported RPDs. Let's look at the tooth and tissue-supported RPD. When forces are applied to the tooth and tissue-supported RPD, the forces must be equitably distributed to the abutments and to the tissues to prevent torque forces to the abutment teeth and excessive pressure to the ridge at the distal end of the distal extension. To accomplish this, the impression is made using a dual impression technique. The first impression of the teeth is made with a conventional impression tray like a stock tray and an irreversible hydrocolloid material like alginate. It captures the anatomic form of the ridge. The second impression is made using a custom tray attached to the framework and a viscous elastomeric impression material like polysulfide or polyvinylsiloxane, which captures the residual ridge in its functional form. The record must be obtained under loading forces. There are factors influencing the support of an extension base RPD. They are 1. Contour and quality of the residual ridge. 2. The extent of the residual ridge coverage by the denture base. 3. The type and accuracy of the impression registration. 4. The accuracy and fit of the denture base. 5. The design of the removable partial denture. And 6. The anatomy of the denture-bearing area. As to the quantity, quality, and contour of the mandibular residual ridge, it is made up of cortical bone that covers relatively dense cancellous bone. An ideal form would be a broad rounded crest and high vertical slopes. The crest of the ridge cannot be the primary stress-bearing region because of its cancellous bone makeup. The buccal shelf from the crest of the ridge to the external oblique ridge is the primary stress-bearing area of the mandible because it is comprised of cortical bone. The slopes of the ridges resist horizontal and off-vertical forces. In contrast to the mandible, the contour and quality of the maxillary residual ridge is as follows. The maxillary ridge is mostly cancellous bone, covered by dense, firm connective tissue, or can be made that way if surgery is done to remove any excess mobile fibrous tissue. The crest of the ridge is the primary stress-bearing area of the maxilla. There's minimal support is derived from the horizontal portion of the hard palate. The lingual and the buccal slopes of the ridge provide some support for vertical forces, but the primary purpose of the lingual and buccal slopes is to resist the horizontal and off-vertical forces that are exerted to the ridge. On the left of this slide, you will see a mandibular cast with the main support areas, the buccal shelf, outlined in red. These are the primary support-bearing area of the mandibular denture. The maxilla on the right displays the main support area in red, and that is the crest of the ridges. Secondary support is provided by the broad, flat area of the palate. As a rule, the broader the coverage of the edentulous ridge, the greater the distribution of the load, and the smaller the force per square unit of measure. It's also important to have a greater surface area in order to withstand vertical and horizontal forces. There is also less rapid ridge resorption that results when the loads on the bone are reduced by having a larger area of base in contact with the tissue. It is also more comfortable when there is more coverage of the bone. Another factor that influences the support of the distal extension base of the removable partial denture is the type and the accuracy of the impression registration. This is the whole point of our lecture today. Begin with this, we'll talk about the residual ridge having two forms. First, the anatomic form is the surface contour when an occlusal load is not being applied to the ridge. The functional form is the contour of the residual ridge when an occlusal load is being applied to the ridge. The two slides above show the difference between the anatomic form and the functional form. The one on the left shows the anatomic form, which is taken with a regular alginate impression in a stock tray. The one on the right displays a ridge in its functional form. Can you see the difference in the two ridges? Unfortunately, these are not the same patient. I wish I had a picture of one in the anatomic form and functional form on the same patient. It would be easier to see that there is a difference in the way those ridges look under pressure. In regard to the type and accuracy of the impression, the conventional tray with a uniform relief, such as our plain old stock metal trays, with a soft impression material like alginate, it's one that has low viscosity, and it records, when you take an impression, the anatomic form of the ridge. The residual ridge recorded under some loading, whether by occlusal loading, by finger loading, by specially designed individual trays, like custom trays with a little bit of space in them and a viscous impression material, that records the functional form. You can make trays with limited clearance for impression material and use heavy consistency impression materials to record the patient's functional form. Another factor that influences the support of the denture base is the accuracy of the fit of the denture base. Support of the extension base of an RPD is enhanced by intimate contact of the tissue surface of the support area by that denture base. The functional form impression enhances this precise fit.
Design of the RPD framework also plays an important role in the support of the extension base. You get some movement of the extension base at the distal abutment. It takes place under functional loading. But the greatest amount of movement takes place at the retromolar pad of the mandible and the tuberosity area of the maxilla. In designing the partial denture, we need to use indirect retainers that will counteract the rotation around the fulcrum line and around those abutment teeth. Movement of the occlusal rest anteriorly to better position the fulcrum and decrease the stresses on the abutment teeth is also called for. An example of this is the use of our I-bar direct retainers. The anatomy of the denture-bearing area may also affect the support of the extension base partial. Ridges are different in shapes and sizes, and that severely resorbed mandibular or maxillary ridge affects the support and movement of the denture under occlusal forces. The shape may also have an effect on support, for instance, that knife-edged ridge. The muscle attachments also play a part in how much buccal shelf is available for support, and the less support, the more pressure on the ridges. You can sometimes tell by looking at a patient's body frame what type of difficulty you may have with their removable partial denture.
There are three factors in the philosophy of design related to force distribution. One is stress equalization, the second one, physiologic basing, and the third, broad stress distribution. Let's talk about stress equalization. The vertical displacement of the teeth is less than that of the soft tissues, so forces applied to the removable partial denture are transmitted to the abutments. Stress directors are necessary, or stress relievers are necessary to protect the abutments. Here's an example of a stress reliever, or a hinge, that can be added to the partial denture so that the forces exerted to the denture base does not get transmitted to the abutment teeth. This hinge allows movement of the posterior flange area and reduces any stresses applied to the abutment teeth. The hinge installed during the making of the framework looks something like this. And as you can see, it allows movement of that area so that forces are not exerted to that or transmitted to those abutment teeth. The finished partial denture looks just like any other extension-based partial denture, except that that back extension base area has movement to it in order to take and relieve the stresses that are applied to the abutment teeth. Why don't we see more of this type of partial denture out there? First of all, it has some disadvantages. Construction is much more difficult and costly to the partial denture. And you also saw frequent pinching of the tongue and the lingual tissues. This type of design also offered poor indirect retention and lateral stability due to the movement of that denture base very easily. Also, that if you get too much movement in a denture base like this, then it can result also in alveolar resorption. The next philosophy of design is called physiologic basing. There's a strong belief that there is a significant disparity between the displaceability of teeth and soft tissue. It's believed that the soft tissue will depress significantly more when the partial denture receives occlusal loading than the movement of the teeth, therefore placing additional stresses on the abutment teeth. It is felt that if you record the anatomy of the ridge in its functional form, you can reduce those forces exerted to the denture teeth. In order to reduce these forces, though, you must depress the tissues during the impression-making procedure, or else you have to make the denture and then reline it so that you are again getting some additional functional loading under that denture base. This picture depicts the physiologic basing concept. The upper left shows the anatomic ridge form in its rest position. In the upper right, you are taking an impression with a closely fitting impression tray and a viscous impression material. The lower left image shows that the denture is then made on this cast that depicts the functional form of the ridge. What actually happens on this denture is that at rest, the denture is positioned upward and away from the bony support area in the lower right picture. When the patient occludes the food, then the denture would depress and it would look again like the lower left-hand side. The disadvantages of the physiologic basing design is as follows. 1. At rest, the prosthesis is not completely seated. You can have high occlusal contacts and inefficient indirect retainers. 2. There's poor stability due to movement of the prosthesis and fewer indirect retainers are functioning. 3. The soft tissues must also resist lateral forces. And 4. Overcompression of the tissue results in rapid resorption of the mucosa and the need for rebasing. The last philosophy of design is for broad stress distribution. Excessive trauma to remaining teeth and residual ridges can be prevented by distributing the forces of occlusion to as many teeth and as much of the available soft tissue as possible. This is accomplished by the use of additional rest, indirect retainers, clasp, and broad coverage of the denture bases and palatal major connector. This is an example of the use of broad stress distribution with large major connector, additional rest, indirect retainers, plating on those anterior teeth. That would be considered broad stress relief. The advantages of broad stress distribution are, 1, the functional stresses are limited and they're distributed over a large area and to the teeth and to the soft tissues. Overstimulation is prevented because of this large amount of support. The teeth and the base areas aid each other by bearing their proportional shares of the stress that's distributed. There's also good indirect retention due to the number of additional rests that may be used, and stability for the lateral forces comes because of the broad contact with the natural teeth and soft tissues. The disadvantages of broad stress distribution are that there's additional support and contact on the teeth, which may cause irritation to the areas. Also, because of the multiple contact with the teeth, the prosthesis may be more conducive to caries formation. A reminder of all our definitions. The anatomic impression form. An anatomic impression is a one-stage impression method using an elastomeric impression material like alginate that will produce a cast that does not represent a functional relationship between the loading of the teeth and the loading of the residual ridge. It records only the ridge at rest. More masticatory load transmitted to the abutment teeth and to the bone that underlies the distal extension at the distal end of the segment leads to bone loss and loosening of the abutment teeth. The functional impression form is the contour of the residual ridge when an occlusal load is being applied to the ridge during the impression. The partial denture constructed on the functional impression cast allows for the maintenance of occlusal contact between the natural teeth and the artificial teeth during function, and at the same time allows for minimal movement of the denture base under occlusal loads. The dual impression technique is a means of achieving these goals. There are two categories of dual impression techniques. One is the physiologic impression technique, and that is used to record the ridge portion of the cast in its functional form by placing an occlusal load on the impression tray during the impression procedure. This is not the one that we use at the University of Louisville. We use the selected pressure technique, and they are intended to equalize the support between the abutments and the soft tissues and to direct the forces to the portion of the ridge that can stand the forces. This is the method we use. This is accomplished by relieving a tray in some areas and allowing the tray to contact the ridge in other areas while taking the impression. The indications for use of a dual impression technique, they are most mandibular distal extension cases because there's only a limited amount of ridge area that exists for the stress-bearing area, and you need to get the best ridge support possible to prevent torquing of those teeth. A long-spanned anterior dentulous space area may be indicated when a minimum of 6 anterior teeth are missing. A dual impression does not improve the maxillary distal extension ridge, which is already usually covered with a firm, well-attached mucosa, or else you've done surgery on it to create that. We do not use this technique on the maxilla. This is a common board question where they try to trick you into saying that it's needed. The selected pressure technique is the one that we use here at the school. The framework first must be fitted to the mouth, and then the impression tray is attached to the extension bases on the framework. There are specifically designed trays that will capture loads in areas designed to support the RPD, namely the buccal shelf area. The master cast is then altered to accommodate this second impression and to create a corrected cast. The technique is sometimes called the corrected cast or altered cast procedure. It's the one most commonly used around the country. The altered cast procedure or the corrected cast procedure starts out, the first impression made before you create your framework is with a stock tray and an alginate impression. The framework then is made on this anatomic cast. It is done, and then after the framework has been fitted to the teeth and the soft tissues, you begin the altered cast procedure.
Let's go over the scenario where you have a complete denture over removable partial denture prosthesis. After phase 1 therapy, you can begin your prosthesis construction. You should first start with the RPD. Go down the step card, and when you get to the master impression, take the RPD master impression, which will be an alginate, and take a primary impression of the maxillary complete denture arch at that time. pour your cast. Survey and design your master cast and get that arch out to the laboratory for construction of the removable partial denture framework. While you're waiting for the framework to be constructed, make a custom tray on your primary cast. It can be constructed of auto-cure resin, light-cured resin, or a thermoplastic material. Trim the tray using the anatomy knowledge that you have so that you have as little adjustment as possible in the mouth. You may want to bring in your patient and adjust the tray to the mouth and border mold the custom tray with gray or green stick compound. I will usually have my patient rinse their mouth with a mouthwash. This cuts the heavy saliva that may have accumulated in the mouth, and then I wipe the mouth dry with 4x4 gauze. Make sure that there's no denture adhesive on the tissues, otherwise you're going to take an impression of the denture adhesive and not the tissue at all. Dry the tissues and record your master impression using polysulfide, polyvinyl siloxane, or polyether. We prefer the polyether as it records the tissue detail better than our polyvinyl siloxane. Then box and pour your master impression as you were taught in the complete denture class and is shown in the picture.
After you separate your impression, trim the master cast back to the land area. Do not over-trim by eliminating that land area. Follow the instructions in the complete denture manual and prepare a record base and occlusion rim on your maxillary master cast. The goal when treating a complete denture patient over a removable partial denture is to have the occlusion rim on the maxillary arch ready when you're ready to add a record base to your partial denture framework on the lower arch. You do not start with the maxillary arch before constructing your framework because you don't want that maxillary master impression sitting around for weeks before you're ready to use it. If you had a maxillary arch extractions, this provides more healing and shrinkage time for the maxillary arch. For the selected pressure impression technique, you must be able to have a good tripod effect when holding the framework in place. This cast does not provide the best tripod support. It is not the best indication for selective pressure impression, even though we're going to end up doing one on it. It can be done since it has a lingual plate which gives you a point of support for the prosthesis. When 22 through 27 remain, what's the best major connector of choice? The lingual plate, the lingual bar, or the U-shaped major connector? This is off of a board question. The answer is the lingual plate, because when you have just 22 through 27 remaining, you do not have good suitable teeth for indirect retention in front of your fulcrum line. But that major connector being plating does help give some stability. As I said before, you must be able to get a good tripod effect or a rectangular effect when holding the framework in place while the impression is being made. This cast provides really good support. It is indicated for a selective pressure impression technique very easily. You do not put pressure on the posterior areas while you're doing the impression. Otherwise, that anterior framework may lift away from the teeth and you'll get an inaccurate impression.
After trying in the framework, remove the framework and block out any excessive undercuts on the cast. A typical place would be in the retromylohyoid fossa area. After doing that, place foil coat over the impression area.
Place one layer of relief over all the extension base area except where the base attachment is located so that the tray will be able to go under that base attachment and lock it onto the framework. This is kind of the relief we use at U of L. This layer will provide a small space beneath the tray for impression material. The tray will be retained by the attachment base. You may remove the wax in the buccal shelf area to add selected pressure in that area which can withstand the pressure. It's marked in red on the cast. Construct a tray on the framework using either auto-cure acrylic resin or light-cured resin. The tray should extend at least 3/4 of the way up the retromolar pad and into the retromylohyoid fossa. Use the anatomy to guide your placement of the tray material. Overextension will only have to be removed when you take it to the mouth and adjust it on the patient. When you take it to the mouth, the framework should be completely seated in the mouth with the tray attached. If not, it needs to be adjusted so that the framework, all of the rest, and the major connector will be completely seated against the teeth. When you take it to the mouth, adjust the tray to the mouth. It should be 2 to 3 millimeters short of the depth of the buccal vestibule when you pull the cheeks laterally and upward slightly. It should extend to cover 3/4 of the retromolar pad and capture the retromylohyoid fossa. On the lingual, the patient should be able to wet his upper lip and place the tongue into the cheeks lightly without dislodging the framework. Relieve over the crest of the ridge in the impression tray down to a thin amount over that base attachment. This allows for some space for the impression material. If the ridge is flabby, you may want to place some holes in your tray over the crest of the ridge using a number 10 round burr. This is to avoid excessive displacement of tissues when the impression is made in the tray. Border mold the trimmed tray to fit the musculature of the mandible. Check to see that the framework remains completely seated while performing this task. Also, have the patient move his tongue to the left cheek and the right cheek, lightly lick his lips while you're doing the lingual aspect of the tray, and then pull lightly on the cheeks outward and slightly upward while border molding. Trim the tray compound on the tissue side of the tray to recreate that space that you created with the relief wax on the cast. You do not want the border molding to be placing pressure on the tissues.
When you have an extension-based RPD, you will use the open mouth technique. After adjusting the trays, paint adhesive in the tray and make sure you use the proper adhesive that fits your impression material. Then allow the patient to swish with some mouthwash mixed with water, and then use a 2x2 or 4x4 gauze and a saliva ejector to make sure that the mouth is very dry. You'll get a better tissue detail in your impression. Then, using the rest and the major connector, hold the framework in place while making your impression. Do not push on the posterior areas. Let it set in the mouth until you can take a fingernail and put a dent into the material and it snaps back at you. It does not leave a dent. It is then set and ready to be removed.
Border mold the borders of the denture while the impression material is setting. Pull the cheek out and up slightly. Massage the cheek from the external aspect, and that kind of controls the thickness of the border that you're creating with your impression. Ask the patient to extend his tongue and to lick his upper lip, and then to lightly put his tongue in the left cheek and the right cheek. When the impression is properly set and does not leave a dent when you place your fingernail in it, take it out and inspect the impression for accuracy and acceptability. Did you take an impression of every edentulous space in the arch? You must do so. You don't selectively choose one edentulous area when you're doing an impression. At this point, take a barred Parker blade in one of the red handles and trim the polysulfide back to the RPD internal finish lines. Warning: at this point begins the most technique-sensitive part of this procedure. Pay very special attention to the detail of the next few slides, and you have to pay very strict attention to detail when you're performing this in the laboratory. Using the saw blade like the one that you use for FPD, saw into the cast just distal to the abutment teeth and remove the cast until the impression fits into the area removed from the cast without any rubber base interference. Remove any cast that is touching the impression material. Note the picture that there's still an interference and that framework is not seated completely on the front part of that cast. The metal framework must seat all the way onto the cast with absolutely no rubber base touching that part that's left in the middle. You should also then, you're going to place some retentive grooves into the cast, which will be shown in the next picture. Make certain that there is space all around the impression material. This is one of the biggest mistakes that is made. If contact exists, then the impression is not completely seated onto the cast. This will cause you a problem after it's been processed. Place retentive holes or grooves into the remaining cast. A couple of examples of how to do that are shown. Then also, before you ever pour this impression, we're going to be soaking the cast so that it's very wet when we make the pour. An instructor may ask you to remove all of the cast except the anterior segment where the teeth remain. This is another way of achieving the same result for the altered cast. That section is placed back into the impression, but it must be placed and secured all the way into position, and then the rest is boxed up as shown in the lower picture. Begin to box the impression much like you would do for a complete denture impression. Make sure that there's no wax that gets into those retentive areas in the cast that's remaining in the procedure. It looks like there's red rope wax in those holes, but they're supposed to be free, and it should be just yellow cast in that area. Place red rope wax, or any kind of rope wax, about 2 or 3 millimeters above the depth of the impression material roll on the buccal side. You want that roll of the vestibule to show in your impression. Your final boxing may look like either of these casts shown above. The one on the left is where you kept just the anterior segment of your original cast. The one on the right is where you cut them and left the middle section of the cast up through the middle of the impression that you have. Before attempting to pour the gypsum material into the boxed impression, make sure that you have soaked that cast so that the two stones will join each other properly, even though you do have those mechanical locks in your cast as it is. Pour with the gypsum product that you used with your initial cast. After the cast is set, you can then remove the boxing wax and clean up the cast. You can also remove the framework with the trays and the impression material attached from the master cast, but you need to be very, very careful when you do this.
Remove the trays from the framework using a torch or a Bunsen burner. Be very careful not to burn your fingers. Sometimes the material will catch on fire, and allow it to burn until the material is soft so that you can remove it easily from the framework. You do not want to warp your framework at this time, or you may not get it to seat properly again.
You're now ready to remove the impression from the cast and clean it up. Remove it very, very carefully, and there may be areas that are locked and may require for you to do some stone work or remove some excess stone that may be wrapped around your tray, or you run the risk of breaking that master cast, especially in those posterior areas, right around retromolar pad. Those seem to be the most vulnerable areas. Then you can add an occlusion rim directly to this framework. The next few slides give you a hint on how to add this occlusion rim. The example shown is actually a maxillary cast, but the same rules apply whether it's a maxillary or a mandibular. The technique for adding an occlusion rim to an RPD framework is as follows. First of all, note the space under the framework. This area is to be used to retain the wax rim. Place foil coat on the areas beneath the base attachment on the framework, anywhere that you will add some wax. And place foil coat until it gets a nice shiny surface when dry. Sometimes it takes 2 or 3 layers of foil coat. It's going to prevent the wax from sticking to the gypsum material. Vaseline may be substituted instead of the foil coat if that's what you have around. First, heat your wax a little bit in the Bunsen burner, and then heat a waxing instrument or a lab knife in the Bunsen burner and cut a piece of the heated soft base plate wax to fit under the base attachment of the framework. Adapt the soft wax to the cast in the areas right below the base attachment. Cut the wax back to the finish lines of the framework. I then take the base attachment and I place it in the flame of the Bunsen burner, and I get the framework very hot in that area, and then seat the framework into the wax until the rests are completely seated and you can see the framework sort of sinks into the wax. Be very careful though, because you can burn your fingers very easily with this. The wax will melt and it'll rise up between the openings in the minor connector or the base attachment. I then begin to heat another piece of base plate wax, and I do it like you do for your occlusion rims. You start to roll it and make sure that you roll it onto superheated wax so that it joins to the other pieces of wax. Trim off a piece that's about the size of the edentulous space, and then melt the surface of it and adapt it to the base attachment area where the wax is coming up through the holes. The wax should then be supported on the ridge and help prevent rotation of the framework during the bite registration. You don't want that framework to actually be able to seat during that exercise. After you have stuck that piece of wax on the base attachment area, you may need to add some additional wax to form a rim on the base attachment area of the framework. Adjust the height of the rim to be at about the level of the other existing dentition and smooth the sides. Carry that base plate down over the ridge so that it gets some buccal lingual support while you're trying to make a jaw registration record. The rims should be very neat and converge to the occlusal and be made to the height of the remaining dentition. The undersurface should be very smooth, and you should cut back the wax to the finish lines on the framework. It is in contact with the ridge and will give you adequate support. The rim is approximately the width of the tooth it is replacing. You're now ready to take your rims and go to the mouth and adjust them to the proper vertical dimension of occlusion. It may be that you would be working with an RPD over natural dentition. You could be working with an RPD over another RPD, or you may be working with a complete denture against an RPD or natural dentition. So you will adjust your vertical dimension of occlusion just like you do for complete dentures, and then you will be taking a jaw registration record using this rim. A jaw registration record may be made with compound. It could be made with polyvinyl siloxane material or some other material like Aluwax. But then once you get your registration, you're now ready to mount your lower cast to your upper cast on the articulator. The case will then be ready to send to the laboratory for tooth setting. If you did not use the functional form to create your master cast, it is possible to obtain a physiologic impression for support of the distal extension base after the partial denture is completed. It consists of adding a new surface to the tissue side of the acrylic resin base that's already been established with your partial denture. The rules for relining a partial denture are followed when this technique is used.
What are the indications for the altered cast? Why would I want to do this? First, I need to take an impression of the tissues under function because the tissue displaces under my base plate and my indirect retainers are lifting up from the teeth in the anterior due to rotation around my fulcrum line. I don't have a solid posterior area when the patient bites down. 2. I received my framework back and I realized that my master cast does not have the proper extension. It doesn't go all the way to cover retromolar pad and into the retromylohyoid fossa. Or I have a very poor quality of that posterior dentulous area with my first impression. 3. I have a really long span in the anterior, at least 6 teeth, and the ridge supplies major support of the prosthesis, and that tissue is rather depressible. These would all be reasons I would do it. The contraindications to doing the functional impression are: if the soft tissue displacement is very slight, the anatomic and the functional contours may be identical. The functional impression would not enhance the function of the RPD. The maxillary extension base does not usually call for an altered cast procedure. We do not do them on the maxillary arch.
How can I determine if I need to do a functional impression? First of all, you can take your framework and you can add acrylic resin bases to it. And then you can apply finger pressure to those bases. If the indirect retainers or the lingual plating lifts away from the teeth, a functional impression is desirable. There is an alternative physiologic impression technique to altering the cast. What you would do is take your impression in the tray that you've created at the extension base end of your partial denture framework, and you can trim it back after you take that impression. Trim back the impression to the finish lines. Then check the accuracy of the impression in the desired extensions by placing it back into the mouth and pushing on the posterior areas to make sure you're not getting any rocking. Then the next step you will do will be that you will take an impression over the top of this while it's in the mouth. You're now going to be taking an impression over the complex that you have already in the mouth, and you'll be using a regular tray with alginate to pull the framework, and at the same time you will capture the impression of the natural teeth in the same complex. When your alginate impression is set, you will lift the impression out of the mouth, and hopefully you will have captured the framework and your altered cast impression or your functional impression in this impression. Inspect it and make sure that everything is okay with the impression, that you have in fact not had it tear loose from the alginate impression, or it may be very difficult to get it accurately replaced in that impression. If necessary, you'll retake it. Trim off the excess alginate back to reveal the borders of the functional impression in polysulfide, so that when you pour it up, you'll get that natural roll there. Go ahead and pour your cast, and then you're ready to remove the occlusion rims from the framework. You'll do some work with your knife to get rid of some of the rubber base, and then with a Bunsen burner, heat up the triad or the acrylic resin to a point where it will peel off your framework very easily, so that you don't distort or warp the framework by trying to pull that material loose from it. You're then ready to add an occlusion rim and basically go back to step 73, where you're adjusting vertical dimension of occlusion. This last technique was shown to you in order to give you a technique that does not require that you alter the original cast. You are, in a sense, creating a new cast with your functional impression incorporated into it. These functional impressions are very technique sensitive and require attention to precise detail when you get to the laboratory, or you will end up having some major problems with your partial denture that may require either a reline or a reline and resetting of teeth. Do not hesitate to get some help from an instructor if you have any questions, please. This last technique can be utilized when you break off critical teeth from your master cast. It enables you to create a new master cast by using this technique.